Welcome to another episode of Let's Talk Small Data with T, where we are passionate about the power of small data in healthcare. I am your host, Tanazia Gonzalez, but you can call me T. Data has certainly changed the game in healthcare. Big data has blown the roof off, but small data, now that's the future. Small data allows us to dive deep into the key insights and take quick, customized action to achieve phenomenal results in performance and quality improvement. Let's explore this today. Thanks so much for joining us. If you have any questions for me or any of my guests, feel free to reach out to me at tgonzalez at eima-inc.com. Enjoy the show. Let's go. Welcome. Thank you so much for joining me for another episode of Let's Talk Small Data with T. Today, I'm super excited to have Dennis Kevogo on the show. He's joining us from Nairobi, Africa, and he will be sharing with us some of the great stuff that he is doing in using small data, big data, and data as part of the Health Recommender program, which I'm excited to hear more about. And I'm excited to share more about what he's doing with you in Nairobi. Dennis is a certified artificial intelligence engineer. He's an MIT certified data leader. He's a facilitator. He's a data scientist. He's a mentor, and he's a tutor. And he's currently serving as data leader with Smart Applications International Ltd. Dennis and I first met in 2019 when we completed the Chief Data Officer Summer School with Carruthers and Jackson, and that's Peter Jackson and Caroline Carruthers. Shout out to those folks. That was an awesome program, and I've met so many people and learned so many things and made so many connections. If you're a data person looking for a course or a networking venue, that's it. Look up Chief Data Officer School with Calibra. Or give me a shout, send me an email, and I'll be happy to share the information with you. Today, though, we're going to focus on what Dennis Kevogo is doing in Nairobi. Dennis, thank you so much for joining me. I am going to make you a panelist so that we can now see your face and start the conversation. So you should be able to go ahead and show your camera. Welcome. And I see you're on mute, so go ahead and unmute yourself.
Thank you so much, T. It's a pleasure meeting you, Gonzalez, and I'm glad that you've been able to invite me to this particular podcast, and it's such a pleasure. Thank you so much.
Thank you. And please, no Miss Gonzalez, no Mrs. anything. That makes me feel very old. Please do just call me T. Everyone's calling me T. So Dennis, once again, thank you and welcome to the show. So who are you? Just take a couple of minutes, give the audience a sentence or two about you and what your background is and what you're passionate about.
Okay, thank you, T. So
Mm-hmm.
basically, Dennis as a person is a very, very charismatic data leader, and
Mm-hmm.
currently I work with the Smart Applications Group, which is an ICT-based company that deals with healthcare automation. Dennis is also a holder of a BSc degree, bachelor's degree from Maseno University in Kenya.
Okay.
Dennis is a very passionate Pan-Africanist. Actually, Dennis has been involved in a number of key projects
Mm-hmm.
across West Africa, North Africa, and even East Africa as we speak under the Youth Spark Pan-African Association. Dennis is also a key leader and has worked with ISEC and has undertaken a number of projects in the said regions. So Dennis is a very committed and proactive data leader who has, of course, before have worked in both complex and simple projects. And that's why I then proceeded to take my certificate in big data analytics from
Okay.
Massachusetts Institute of Technology, and also proceeded to be a certified artificial engineer with the Artificial Intelligence Institute. Other than that, Dennis is a man who loves traveling. I love traveling a lot, and I love impacting the society. That's why you could hear from my introduction, I've done one or two things that touches the African life. Thank you.
Okay. I love that. Issues that touch the African life. That's beautiful. I mean, I've been doing a lot of talks with folks who are serving the community,
Okay.
with their passions, and that's exactly what you're doing.
Amazing.
Um, I'm really excited to hear more about this health recommender. Now, what is that?
Amazing, amazing. So allow me to give it some context or perspective.
Hmm.
Perhaps you love Netflix, or perhaps you love YouTube. Exactly.
Yeah.
So the key algorithm behind the functionality of Netflix and why it can get a number of viewership and
Hmm.
generate money is what we call a recommender system or a recommendation engine. Why am
Okay.
I giving it a context? Is because that is more relatable to you than even what we are going to talk about today, which is HRS, Health Recommender System. In short form, we just call it HRS. So basically, as is Netflix to the viewership, or rather to those who like watching movies and seasons and series, sorry. So that is a recommender system to healthcare. One, one of the most immediate functionality or benefit of a health recommender system would be doctor to patient recommendation. That's one of
Hmm.
them.
Okay.
Patient to a certain activity, for example, a sports activity, a healthy living lifestyle. For example, those who
Hmm.
are living with chronic diseases, we would be able to design or build a health recommender system that can be able to recommend patients that are suffering from chronic disease. For example, those who are diabetic, we've
Hmm.
been able to develop a health recommender system for the patients that are diabetic
Hmm.
based on a longitudinal history of that patient. When I talk about a longitudinal history, we're looking at what is their BMI, what is their age, what is even their origin in terms of demographics, because
Hmm.
those are the many parameters that build up for us to build a health recommender system.
Hmm.
So basically, a health recommender system is a recommendation system that is used to filter out certain specific items that would be of meaning or meaningfulness to patients likely suffering from chronic diseases. We focused more on chronic diseases. So that's in a brief, in a snippet, that's what I recommend a health recommender system is.
Awesome. I mean, it's
Just
so many uses I can think of for that. As far as access to data, what's your main data
exactly.
source?
Okay, thank you so much. So our main data source that I've used also to build up this health recommender system is directly from the hospitals. In Kenya, we call them providers. How do we tap into this data? How do we source this data? We source it from what we call the biometric systems. One of them being like facial recognition when you check in into a hospital, for example. Another one
Hmm.
being the card. We normally have a smart card in our company that when you
Hmm.
swipe, it contains all your information from claims to health. So generally, it would
Interesting.
even tell that actually T has a benefit cover of about 2
Hmm.
million US dollars, and Dennis has a benefit cover of about 1 million US dollars. And when you look at the past 2 years, T has never visited the hospital, for example, and Dennis has visited the hospital because of COVID-19, for example. So
Hmm.
can we then recommend a likely lifestyle or a likely food or a likely something that would be able to, of course, help us or help
Hmm.
that patient mitigate against the likelihood of course, dying earlier. That is, of course, now increasing the life
Hmm.
expectancy. And of course, there are a number of factors that would come in when it comes to the likelihood of morbidity or
Hmm.
even mortality when you talk about a patient.
Okay, so wait a minute. One thing I think I want to clarify for the viewers and myself,
Exactly.
I live in the US
Oh,
and
exactly.
we do not have universal health care. Is
Amazing.
that not the case in Africa? Is there
Exactly.
universal health care there?
There's recent universal healthcare. And I'd like to mention this that smart applications currently, we are working with World Bank on a project
Okay.
to pilot universal healthcare in a number of counties. Maybe I'll just mention a few. We have Kisumu County, which is in the
Mhm.
western part of Kenya. The government is doing a piloting on universal health cover, or rather healthcare. And what happens? They're using our data and our analytics to be able to decipher and be able to get the financial gap, sorry, so that they can be
Mhm.
able to know then
Mhm.
as a government how much would they need to pump in financially for us to achieve universal healthcare, because the
Okay.
greatest gap, the greatest missing link
Interesting.
in Kenya when it comes to UHC is what we call financial coverage, rather financing, the financing of healthcare. That's the biggest problem. It's because the larger population is
Right.
actually of the poor. Most people are living below $1 a day, are living under, yeah, very, very adverse.
Okay. So, I mean, the reason why I asked that is because you had mentioned a card, and people are swiping this card as they're
Good.
using the hospitals. And that is tied back to the universal healthcare question.
Exactly,
And so
exactly.
everyone has this card, and that's how you're able to collect data on
Good.
all of the patients, right? Because
Oh,
everyone's using this card. Is that accurate?
good. Allow me to respond to that. So basically, we have about Kenya has a population of about 57 million.
Okay.
Rather, no, not 57, but 50 million. Sorry, 47 to 50 million around there.
Okay.
And currently, those who are using our smart card is a population of about 3 million, meaning we've covered about 3,000 hospitals and 71 hospitals, and it's strictly corporates. So we are still talking about those who can afford. We've not
Okay.
even touched those who cannot afford. This is for
Okay.
those who can afford, those whom their employers can be able to cover them, pay for
Yeah.
them, pay the premiums for them. We're also talking about those who, of course, are the Robin Hoods, those who can be able to afford and they can be able to pay for themselves. Those are those who are under our cover, those who are using our cover rather, or our cards.
Okay.
Yes,
Okay.
exactly. Yes,
So the population that cannot afford,
exactly.
whole different conversation.
A whole different conversation,
A
and that's
whole
why
different
we
conversation.
a totally different conversation, T.
Okay. Okay.
Exactly.
Interesting.
Yeah.
Okay, so as part of the health recommender team, so to speak, I'm assuming you have a team that's working with you on this project, and you have doctors that are working as part of this, like looking at the recommendations and validating the recommendations before they're shared. How does it work? Like if I'm a patient, how do I access the recommendations from Health Recommender? Is it an app?
Okay. 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 Good. So this is what we call a wellness initiative. A wellness
Okay.
initiative. So when we talk about access to that
Mhm.
particular patient, it will be directly through the employer. For example, if you are under a cover known as T, maybe you're under an insurance cover known as T, we will be able to send out recommendation to that insurance cover known as T and tell them that actually a larger percentage of those whom you cover are suffering from diabetes. Reason being, during the COVID-19 period, most of people were just staying at home. So they were consuming sugars, high on sugar, carbs,
Yeah.
and so on and so forth. So the susceptibility to suffer from diabetes, be
Okay.
it type 1 or type 2, increased. So we advise the insurance company, because at the end of the day, you also want to save your money because you want to minimize on the number of claims. Those who will
Yeah.
go to the hospitals and you pay for it. So we send out to them a wellness initiative program on how they can then initiate in their organizations in order to protect their employees. So we do not have a direct contact with the patients. What we do,
Okay.
we have a direct engagement with the hospitals. We also have a
Uh-huh.
direct engagement
Uh-huh.
with the insurance companies and initiate a conversation on wellness initiatives so that
Okay.
it can be able to then channel even via mail and even YouTube actually, so that they can be
Mhm.
able to follow up and see that actually we need to live such a healthy lifestyle for
Mhm.
us to avoid chronic diseases, for example.
Interesting. So yeah, the title of the talk is actually from predictive analytics down to small data action. And this is what you're describing, right? So like in COVID, you were able to predict the impact of the pandemic, and say, hey, this is what we're predicting and this is what we're seeing in terms of the activity. Here are some recommendations for your consumers, so that you can avoid this amount of money exiting your eco
Exactly.
stream, so to speak. You
Exactly.
know,
So actually, essentially,
here's like a
based
heads
on
up. Hmm.
exactly. So, based on predictive analytics, we could be able to actually predict likely claim amounts. Could be able to tell hospitals that you should expect in the next 3 months,
Okay.
this will be the average claim amount, and it will come from
Okay.
perhaps HIV/AIDS, or it will come perhaps from other
Right.
respiratory diseases other than even COVID-19. That's one. We could also be able to predict and forecast drug dispensation. You could be able to
Okay.
tell the hospitals that the likelihood that you're going to fill up your pharmacies with so and so drug, maybe azithromycin, is
Okay.
this chance or that chance. Okay. And of course,
Interesting.
that is
Okay.
based on a certain level of accuracy. It may never be
Okay.
100% accuracy per se. Even if a machine has to come from from the showroom right now, it is never 100% effective. So
Okay.
those are one of the two of the key measures. And then last but not least, we'll be able also to predict the patient traffic and tell hospitals that you should expect that in the month of September, we are in the month of April, in the month of September, because there is an expectation that the number of COVID-19 patients is going to rise. Why? Because of the susceptibility, the spread, and the likelihood of a certain
Interesting.
population contracting COVID-19 is high. So you should expect your numbers to be low. Those will be visiting. So where are we shifting to? We're shifting to what we now call telehealth care. So most people
Yes.
or most hospitals would then prepare for telemedicine, teleconsultation, and so on and so forth. And of course, now the advent of telemedicine came in and people saw that there's actually a gap here. There's an opportunity for us to explore other than just waiting for that moment to come.
Right.
And like I said, it can never be 100% effective or accurate. And that's where the doctors come in. We have a team of 2 medical officers who now would be able to give me an epidemiological kind of interpretation of how it's going likely to be based on the diseases, based on the drug dispensation, and of course the trend per month, and based on the season, and even how the weather looks like and how it's gonna change. Rather, it's going to change from one time to another. Yeah.
2 questions. Number 1,
Exactly.
how far into the future do you all predict in general? Is it like 12 months, 24 months? Like for on general,
Okay.
we predict in the next 12 months, XYZ will happen.
Okay, good. So that will take us to narrow down to what we call machine learning, of course, which is also an item of health recommender system. Because as you
Oh, that
train your
sounds like
machine,
big data stuff. Yeah, but
exactly,
go ahead.
But I don't want to run away into that. So basically, we have to train the health recommender system with what we call machine learning, both supervised and unsupervised. For supervised, it's labeled data. Unsupervised, it's unlabeled data. Part of the I don't want to mention some of the algorithms therein, but now generally that depends with the size of the data, the amount of the data we have. That's one, and then on the quality of the data.
Yeah.
So, for example, if I have data on hospital that is from 2018 quarter 1 to 2019 quarter 4, for example, I can be able to then predict 2 years or 1 year to come that this is what is likely going to happen. So normally for me, I just pick a pattern, a historical pattern that has happened before, for example, 3 years before, and then predict 3 years into what's likely going to happen.
Okay.
But then you need to also set a level of assumptions. You need to have a set of assumptions so that you tell them in the advent that a disease, a pandemic comes, for example, COVID-19, these might not likely be the same case. And then you give a certain level of confidence interval that likely our accuracy will be around this range or that range. Yeah. So that's very flexible based on the amount of data, the quality of the data that we have, and then you can be able to predict into the future. But more commonly, annually, a month or 1 year or so.
Very nice. I mean, certainly enough time for the recipient to take the information and be able to put into action a plan to, address those concerns. Secondly, have you all ever done like a look back to say, okay, a year ago we predicted XYZ, here's what actually happened, and comparing the prediction to the actual outcome?
Okay, good. I think that would take me back to COVID-19 once again. We sent out an advisory to part of our customers. Likely this is what is going to be when it comes to the numbers and the figures. And we'll do a blind analysis from one customer to another and tell them, based on what we can see in the industry and based on the data that we are getting, this is what the numbers are going to look like in the month of September. And actually, based on that reflection, we could be able to see that come September 2020, whatever we were predicting in the month of April was actually a true reflection, a very true reflection of what we had foreseen in the month of April. And that's what now will take us to what we call decision intelligence. It's based on decision intelligence. It's no longer heuristic. It's no longer heuristic, sorry. It's no longer based on emotions, based on just what you think, what you feel. It's no longer highest paid person opinion, but it's based on data and
no
data.
longer anecdotal. Yeah.
No longer anecdotal.
No longer anecdotal, it's fact.
It's
Yeah.
fact.
And the data,
Exactly.
the numbers never lie.
The
Yeah.
numbers never lie. The data will speak for itself.
It
For as
is
long
what
as
it
you want,
is. Yeah.
it is what it is. Exactly.
I love that. Yeah.
Yeah.
No, no, I love what you're doing, and it's a lot of stuff that I do in my everyday work that I could totally use a tool like that, especially when we're talking about value-based care and working with these value-based payers, and we're getting graded on specific metrics in our quality improvement plans, and payers, and understanding where we need to be in our quality metrics, and predicting what that translates into in terms of dollars. Um, so now, the show is primarily to talk about small data, pretty much
Exactly.
what folks are doing with data and how they're
Exactly.
using data to drive quality improvement, which is what you're doing. But my sweet spot is talking about improvement in patients' lives, and
Exactly.
actually seeing it materialize because of the data we have access to and how we're using the data and taking action with the data. Question: do you have any success stories that you can share of a hospital where you share the information, or health insurance plan where you share the information, they took some action, and then there was a great outcome, or even a story of an individual patient that your actions have impacted?
Wow, wow, wow. Thank you so much. Thank you so much. I think I would have first an internal reflection onto our
Okay.
company, and I would give it a very candid perspective, even with the hats of my company off,
Hmm.
and in such a reflective perspective, so that you can be able to speak also to the power of small data.
Hmm.
That basically, even with an employee population of about 150, we
Hmm.
could be able to get information on the trend of the diseases within our organization. So what happened? Given that we have a team of medical doctors, they could be able to advise on wellness initiatives, of course, inclusive of a number of key activities, sporting activities, which we actually advised every day. We even have a WhatsApp group called Smart Wellness Initiative.
Okay.
That every day you are advised on what to eat, what not to eat, what activity to do. We even have internal competitions with incentives therein on how to then ensure you are living a normal life, you are living a
Okay.
healthy life. What
Right.
has that translated to? As a company, we've seen a biggest drop in the amount of claims that the company has been able to pay for.
Okay.
So we've saved a lot of money, and we're not saving based on just the fact that we had wellness initiatives, but we are saving because our data could speak to the actions that we want to see
Right.
intelligence coming from. And I think that speaks to the aspect of value based care as well. And I'll speak about one particular hospital here in Kenya called
Mhm.
Gertrude's Children's Home,
Okay.
who have been on our business intelligence system for quite a while, which is a little bit different from the HRS. And they've also been able to see a margin of profits. And also based on operational effectiveness, they could be able to see that in certain departments actually would need more nurses because there is actually some strain uh, in some departments compared to the others. What has that led to? It has led to an increase in the value-based care. And value-based care, when you talk about value-based care, you're talking about increase in the quality and maybe a significant reduction in the quality, in the cost of Medicare, or
There you go.
perhaps
That's what
averagely
it's
around
about,
there.
right?
Exactly,
Improvement in
exactly.
quality, reduction in cost. Hmm.
Exactly. So we could see that even for Gertrude's Children's Home, they would see an increase or rather a reduction in the number of lives that are visiting them there. You see, that would be a quite of a paradox for us, because you would wonder, if you offer such wellness initiatives, the hospitals are likely going to lose the number of patients. They're likely going to lose money. But the question would be, do they have the value in mind? Do they have the aspect of value-based care?
Yeah,
Because when you look at longevity, at the end of the day, it will even translate in an increase in the numbers at the end of the day, because they can even come there to visit because they also want to have a conversation on wellness initiatives as
right.
well. Exactly. I think that's pretty the two use cases that I can mention that I've seen actually data speak and
Nice.
bring out what we call actionable intelligence.
Love it. I love it. And
Exactly,
yeah,
exactly.
it's so like it's that paradox, right? You know, that you have the hospitals, you're trying to improve the quality, keep the folks out of the hospital. But we need
Exactly.
to get away from the inpatient care and start focusing on the ambulatory side,
Ambulatory.
like
Exactly.
start pushing primary care, and connecting these patients who are constantly hitting up the ER, the emergency room, and the cause of readmissions because they're not following any kind of wellness program or not being mindful. We want to drive them towards primary care or ambulatory care. I'm not
Ambulatory.
sure if these same phrases are used where you are in
Yeah, it's
Nairobi.
okay.
They are, yeah.
Here we ambulatory is outpatient, but it's
Yes,
yeah,
outpatient. And yeah, so just really having a team or a provider responsible for a patient and making sure that the care is well rounded and taken care of, especially for chronic populations like the
exactly,
diabetics. So a
exactly,
number of guests that I've spoken with, they brought up specifically the diabetic population.
exactly.
Obviously, this is a population with costs and lots of initiatives to help drive down the cost, improve the quality, and you have to really work with the patients to educate them about the daily um, tactics or tasks that they can do to improve their wellness, not just, you know, in nutrition, right? Nutrition is very
Yeah,
important,
yeah,
but exercise and, you know, the
yeah,
medication and the finger sticks and all of that.
exactly,
Yeah.
exactly, exactly.
Yeah, no, so I love the work that you're doing, very interesting, and I could just think of so many applications
Exactly. I
and
think
all the work, yeah,
exactly.
that
I
I'm
think
doing.
we can never have enough of this. I'd be very honest,
No,
because
totally.
other than food recommendation, we can have physical activity recommendation. We can have
Hmm.
drug recommendation. You can even health status prediction recommendation. I
Hmm.
mean, the spectrum is quite large, and
Yes.
we can look at entirely where what is the next frontier. Because currently, if we then want to bring in even the aspect of artificial intelligence, because that's the next
Hmm.
thing that we are looking at as a company. That's our next. It's on our vision board. That entirely, can we then bring in the aspect of artificial intelligence? Can we bring in the aspect of neural networks, which is one of my majors as well?
What
That's
was
one
that
of the
again? Was it physician intelligence? Is that what you said?
artificial intelligence. Artificial intelligence.
Artificial AI. Yeah.
Exactly.
No,
AI.
definitely. Yeah.
Exactly. Currently, we're talking about narrow artificial intelligence. Then, are we going to general artificial intelligence? Are we going to? Shall we be prepared for that particular advent? Because that goes line in line with the fourth industrial revolution. I would say largely the African population and even the Kenyan population, statistically speaking, actually, we are a
Mhm.
bit behind. But then, when you look at the penetration of technology, the penetration
Mhm.
of even education is increasing actually
Mhm.
at a very high rate, and not quite gradually but spontaneously. And I would
Mhm.
say that in the next 2 years or 1 year as a company, we shall be fully prepared to even bring the aspect of robotic process automation, so that entirely we can even automate the process of mapping of drugs. Because, for example, maybe I didn't mention this. If
Mhm.
I want to do an analysis of my data, I'll find data from hospital A. They've said malaria, for
Okay.
example, and then hospital B have said malaria too. But it's still simply the same thing. So I have to map that so that entirely when I look at my data and I want to derive statistics, we are talking about one data. You're talking about one particular parameter. You're talking about one particular feature. You're talking
Uh-huh.
about malaria. But then
Yeah.
others would even just write unknown. But then we have designed a way of mapping. And that's where now artificial intelligence and robotic process automation is coming. And I hope that even as we move to that era, we shall be prepared to change the lives of the African population. We want to speak a language of a leader. We want to speak a language of a Pan-Africanist. And that's why we are not just in Kenya. Yes,
Mhm.
we're based in Nairobi. That is our HO. But we're also in Malawi, quite a largely population of the poor. We're talking
Mhm.
about Rwanda, we're talking about Mozambique, we're talking about Zambia, we're talking about Somaliland.
Mhm.
We're also talking about Ethiopia, which we've just entered the market very recently. We're speaking of the change that would be impactful. We are not just in business, but we are here for change. We are here to reach out to the population that is
Mm-hmm.
disadvantaged, population that maybe they would wait upon the government. Today in Kenya, we're talking about loans and loans and loans. Every head, for example, in Kenya, is supposed to be, even those who have not yet born, is supposed to be, has a debt already of about 500 USD or more, actually. The unborn, you can imagine. And that would even translate to a lot of money because as we speak, we are still borrowing and borrowing and borrowing. The issue is that I'm not complaining, but I'm here to say that yes, there is a solution. But do we even have key partners? Do we have people we can collaborate with? Do we have people we can talk to? People that will help us even get more meaning out of the data that we have. People that will help
Yeah.
us see whether we can achieve universal health cover. I think it's not a coincidence that when you talk about Europe and even the US, for example,
Mm-hmm.
when you look at the life expectancy, it's a little bit higher compared to the African population.
Mm-hmm.
Or if you want to compare maybe South Africa as a country and Botswana, which is a very poor country, which is
Mm-hmm.
actually it's in the third tier when it comes to economies. South Africa could be actually a middle income. So you can see there's such a disparity when it
Mm-hmm.
comes to healthcare and health coverage. It's not a coincidence. It's because there are already infrastructure, systems, and even
Mm-hmm.
technology that have been put in place to enable. Those are the key enablers to ensure that many lives are saved, to ensure that the quality of Medicare is improved, and to ensure that we are shifting from just curing, detecting and curing, but we are now predicting and preventing so that as we predict in the
Mm-hmm.
near future this will happen, you will prevent that from happening, and that will shift us to what we call preventative healthcare.
No, that's totally. Thank you so much for that. I love it. Obviously, we're doing the same things over here. A lot of us across the globe. I mean, that's one thing I'm very grateful uh, to you and all of the other podcast guests that I've spoken to over the months. That's what I've loved. I've entered into this journey of this podcast, and it's allowed me to meet so many people in different countries to talk about how they're using data, what they're doing, what they're driving. And I love what you're doing with
Thank you.
your group. And first of all, I'm a Netflix lover, so
Yeah,
I can
amazing.
completely understand what you're talking about.
Mhm.
But obviously, I'm in healthcare also,
Great,
obviously in
great,
healthcare data. So I live and breathe in healthcare data, and I love that you speak in numbers.
great, great.
So it's a beautiful thing because you get to see where you are with the numbers, where you want to go, and measure your success as you're putting into to play your interventions, your action.
Exactly,
You know
exactly.
your wellness plans and all of that really. And you said something really beautiful, which I love. You want to improve the lives of the African people. um, and it's such a beautiful thing. I mean, I've that's why I wanted to bring folks together on this podcast to really talk and meet with each other, building a community here around data. And I'm really thinking of a way where I can bring a number of you all together on a roundtable and just talk about the initiatives that you're working on and how we can help one another. So this is why we're here.
Okay,
Um,
amazing. I think
no.
to that end, before you continue,
Mhm.
I'm also part of the Data Professionals Association of Kenya. I'm one of the
Okay.
board members. So I
Oh,
think
nice. Okay.
I can be able to speak to a larger population, those in the
Hmm.
industry, those who've started even way before me. I'm also part of the Maseno University Alumni Association.
Okay.
So perhaps I'll see how I can be able to consolidate this team, bring us together, think on how we can collaborate, think on how we can move
Hmm.
forward together. And I really appreciate this particular platform by UT. This is really
Hmm.
amazing.
Thank you.
I would wish even to divulge more into Netflix and give you the nitty gritty, but I know that's not the agenda of the day. So maybe I'd welcome you, of course, to continue, and then I
Mhm.
throw one question to you, just to feel how does your market look like, how does the United States look like, and generally the Americas look like compared to Africa.
Oh, yes. No, totally. We have this something called the unrest going on over here with the death of George Floyd and just issues pertaining to race, and we over here, we're such a melting pot. I mean, I'm in New York physically. And we have a multitude of races and cultural cultures, and it's just a large, a diverse group of individuals trying to live together as one in this place called America. So I, like you said, you are really trying to improve the lives of Africans. You know, you all over there, I'm trying to improve the lives of Americans. And, you know, trying to create this talk show so that we can get on here and talk about our passions and really how we can help one another and hold our diversity as uh, a beautiful tool to help us get there, not a barrier. You know, so like over here, it's a real focus on how do we appreciate and value our differences as opposed to and make it part of the goal to um, improve the lives of Americans. Americans, one word, you know, one team. Um, so, you know, and I'm happy to be a part of that solution.
Exactly.
And thank you so much for sharing your work with me and the listeners and telling us all about, you know, the population you serve and the situation over there is just, it's so interesting. I would love to hear more about Health of Recommender and some of your other projects. Perhaps we can
Exactly.
have a part 2, 3, and 4
No
and
harm,
bring
no
you
harm.
back on and we
I'd
can
love to.
continue. Yeah, we can continue the
I'd love to.
conversation. But we're coming to the end of our time.
Exactly.
And Dennis, thank you so much for joining me and letting us know about what you're working on and Health Recommender and the population you serve. Any last comments before we close out?
First and foremost, thank you so much, T. And maybe I'd also inform you of our next project is what we
Okay.
call chronic disease management. We are
Okay.
trying to develop a chronic disease model, which will just give us a prediction of the susceptibility of a certain population suffering from a certain
Okay.
chronic disease. Yes, exactly. That's the current project that we're working on. And maybe I'll
Mm.
be able to brief you, and then we'll have to talk more.
No,
But
totally.
last,
When is that happening?
okay, that should be happening in quarter three of 2020.
Okay.
So you'll get to hear more about that in quarter three of 2020. So perhaps the start of July around there or June around there.
Nice. Okay. Well,
So
I will
yeah.
definitely keep an eye out, and obviously, I will be connected to you. I'm connected to you, so I will ping
Exactly.
you often.
No
Uh,
harm, no harm.
so, but
If it gets to on the table sooner, I'll also be able to brief you. So mine is to say that thank you so much for the invitation to this particular podcast, and I'm
mhm,
grateful. It was really amazing. I really enjoyed. It was
yeah,
quite freestyle. I spoke with my work hats off. I spoke with my heart as an African on. I spoke with such a resound mind to bring change. I think at the end of the day, what we are endeavoring for is that can we see a change, and it's going to be both vertical and horizontal. Can we be able to touch
yeah,
every other population? Can we be able to influence the lives of as many people as possible at a go? That's what we're talking about UHC. Then, even as much as we are a private company, then what is going to be our role when it comes to enabling the government, enabling even NGOs in supporting such initiatives to ensure that the population is covered and that no one is going to suffer, or
right.
rather if they are going to suffer, then they are covered, and healthcare is also accessible to everyone.
Yes.
So mine would be to say that I would still take lead, and I would still speak in the same voice, with the same energy, with the same vigor, with the same oomph, to ensure that this is going to be achieved. And the blueprint is clear. The
Mhm,
blueprint is out here. That as a company, as myself as an individual, I'll speak the voice of the African people, the voice of change, and
yeah.
the voice of bringing healthcare to the lowest level, to those who cannot even afford. And we are talking about quality healthcare. Thank you
Yes.
so much, T. I'm most grateful.
Thank you. I just want to say I love your energy. I love what you're
Thank you so much.
doing. Yeah, no, I've
Thank you so
thoroughly
much.
enjoyed this, and thank you so much for being a part of the show.
You're most welcome. Adios.
Thank you to my listeners for joining me today. Uh, I hope you enjoyed the show, listening to Dennis's work that he's doing over in Africa. I thoroughly did. I'm looking forward to having him back on the show. And to subscribe to the podcast, you can find us on Spotify, iTunes, iHeartRadio. You can also go to www.eima-inc or inc.com and click on Let's Talk Small Data. And there you can access episodes of the podcast. You can also see us on YouTube. You can access the YouTube profile on that page too. And this brings us to the end of the program. And I want to say, I hope you have a lovely day. And remember, unleash the power of your small data. It's your most valuable and strategic asset. Have a nice day and see you next time. This episode is brought to you by Effective Information Management Systems, specializing in healthcare small data and offering expertise that goes beyond technology. Visit www.eima-inc.com